All right. Good afternoon. I'm happy you're here. I thought there would be one person. Because you got to put that on to hear me.
You have to?
Well, you can hear me probably up front. So anyway, I know I'm standing between you and happy hour, so I'll do the best I can do here. The title is, how to see pre-visible caries. And the reason I'm talking about this is years ago, I met with Carrie Haggerty, and she happened to be with Incisive Technologies. And in the U.S., you guys probably know me for dental materials and prevention stuff, but I was doing a lot of early diagnostic stuff. And the reason you don't know about it is we had great results, but nothing happened with it. Nobody picked up patents because it would never get accepted by the FDA or the ADA or insurance companies. So anyway, I was asked to talk about that, and I kept up to date with the BlueCheck. It wasn't called BlueCheck at that time. It was just a blue dye, and what carried it was a protein, which happened to be hemoglobin. And so, they hung out, and I kept up to date on it. So, I know about it, but I've never done any hands-on research with this. So, anyway, I want to introduce it to you because it's new and it's kind of cool. So, I think it's easiest when I disclose is I got a gob of money from a lot of people over the years. Last I heard is over 41 million. I don't know, between 41 and 42 million. So I'm not going to list them because it takes too long and I only have an hour. But I am a paid consultant still to the United States Federal Drug Administration. I'm still a paid consultant to the United States Center for Disease Control and Prevention. I have never been a paid consultant to industry ever, including Incisive Technologies. They give me some money for this, maybe, I don't know. Maybe it depends on how I do here. But anyway, I wanted to do this just because I know these guys, and I thought they were really nice about letting me follow up with them over the years. So I think we all know caries remains a problem. So what I'm going to talk about today was, the early diagnosis work I did. And I spent a significant amount of my career, like 10 years on it. Why nothing happened with it, and then introduce the BlueCheck to you, to Incisive Technologies. So I had the privilege of being the chair of the first consensus conference of the American Academy of Pediatric Dentistry, and it happened to be on restorative dentistry. And I also was the chair of the update on that in 2015. And what we always based all of our restorative on is we believe in prevention first, and I know you do too. And so we make it clear you don't go to restorative until you have to, and that means you have enamel breakdown, right? And so you use other technologies. Well, the earlier you can see it, the better it is to intercept, right? And so, what made it happy for me was we could really get into early things with, fluoride varnish, maybe lays or something like that. Well, what happened on the earlier ones is people thought, oh, this is a way I can cut sooner and make more money. And that was never the idea or the intention back when I started. This is almost 20 years ago. So, we get into the age 1 dental visit that was recommended by the American Academy of Pediatric Dentistry. You guys look pretty darn young out there. It was first introduced, in 1985. And it took like 20 to 30 years to even be recognized. But the idea at that time was push prevention young before they have caries, right? And so it just made sense. Why not try to diagnose things early? But, we couldn't see it visibly until it was a white spot lesion. And a white spot lesion, is about a 0.5 millimeter, 500 microns by the time you see it. So, of course, we were recommended to find things earlier. And so we had a federal grant, a large federal grant, to start to look at early diagnosis. So we had put a group together. The principal investigator at Indiana was George Stuckey. The principal investigator at Iowa was Jim Wafel. You might have read these names. You probably don't know them. You do. And I was the principal investigator down in Texas. And we started looking at these different methodologies because I had developed a technique which was nothing super smart. You know, I got kids to give me their teeth back. Is that just cool? And you know, you have to go to the federal government when you write, you know, a $5 million grant and justify, you know, that you're going to do something with it. Well, you know, they said, "Are you going to get the teeth back, Kevin?" I said, "You know, as a tooth fairy, we're paying $25, and oh, you can get teeth back for $25. Let me tell you." So anyway, we did all these examinations to try to validate the different systems, and then we came back after that. We got the kids to give us their teeth back and paid them a fortune, and let me tell you, you get more teeth than ever was entered. They give you every tooth in their mouth. And so we got them back and we sectioned them and started looking at them with all these techniques. And we wanted to see if what we saw clinically, we also saw microradiography and through other microscopically. So this is my part of it. I'll buzz through this quick. Like I told you, these were the PIs. And the feds were really interested to find this early diagnosis so there wouldn't be such early cutting, right? And it totally makes sense. It fits into what every one of you was taught, prevention, right? So what we found was through looking at all those different systems I told you about, or showed you, was that QLF was definitely the most accurate. Quantitative light fluorescence. You could detect approximately 10 times more demineralization than any other system we used. And just to remind you, that includes laser fluorescence, diagonodent, your visual examination, and a couple other images. The fiber optics were not clear at all. So the sensitivity and specificity of the techniques were affected by lesion depth. You know, obviously, you with your eyes, the deeper it is, the more you're convinced it's there. And you know, you guys are way better diagnosticians than you think you are. I mean, you flip that mirror around and you see white spots, and you see them quick, way faster than parents see it. So anyway, people were saying, "Kevin, you're really getting hammering on diagonodent." I said, "No, I'm not. It can be helpful, but you will find that it's not the answer." So when we went through this by validation, we found QLF to be the most accurate, visual exam, you guys, to be the next most accurate, then the photo systems, and diagonodent, the infrared laser, the least. So we could obviously, with QLF, see less than 100 microns. We later validated that we could accurately diagnose up to 50 microns. I mean, that's really shallow, guys. Really shallow. It's not a tornado, it's okay. Yeah, of course, the bigger the lesion got, the better off we were. So we decided we're going to use QLF. We thought it was the most accurate. So we went into phase 2 of our federal grant, and this was what we were using at the start. With QLF, this is through Inspector. That piece of equipment there, for you from Canada, welcome. For you from the US, this is what your federal dollars paid for, 85 grand a piece. And we bought 2 of them. So thank you for your support. So we went through these, and you know, one of the things we didn't like, this was the headpiece. Tough to get in the kid's mouth. But you could see things so much earlier, you know, because of the fluorescence. And so, you know, you could see things you really couldn't see outside of that. And so we were pretty happy with this. So we started this next phase of our study with 119 children, 8 to 12 years of age. And, you know, we examined their mouth with QLF, and when we saw early lesions, we'd snap a shot and save it. Now think what you have on your phone right now, how much you can store on that. we had one of those boxes that stood like this tall and this wide to save the images because it was so cumbersome at that time. But then when the kids sent us their teeth back, we had predetermined sites that we knew we were going to section and validate with polarized light microscopy. And so we did that, a lot of sections. So this is kind of just an image. This is a baseline image with the QLF inspector machine we used. But what I want you to notice right here, it runs a regression analysis on exactly what position you're in. So when you come back, you can set it so you have to be within 3% of what it originally was, so you're not creating any shadows to make it look differently. And it was kind of cool. And what we found through all that was polarized light microscopy validated that D-min was seen, that was seen with QLF was accurate. It was really there. And that we could diagnose it at 50 microns accurately. So that was the best that was out there at this time. Now remember, this is like 20 years ago. This is before a lot of you started practicing. And so we took it to the second phase because it was being published. I guess the biggest person was Kidd from the UK saying, you know, you're doing more restorative now, not you guys, but in general, dentistry altogether, for secondary caries now, recurrent caries. And so we didn't know if it was accurate for that. So we went back, did another phase 3, used 200 children, again 8 to 12, put class 1s and class 2s on them, followed them every 6 months until those teeth exfoliated. Again, we sectioned them and validated what we'd seen with QLF with polarized light. And this is an example, baseline image. It's at basically 97% the original position on the second one. And so you could see things quite clearly. And longitudinally, you could follow it. And this was like the only thing out there that was really very accurate at this. And so we were pretty happy. And so you take it and report it. You know, we reported to the scientific community. They all loved it, right? Insurance didn't like it. They said there's too many chances you can change the program. And although it looks like you're restoring at necessarily 97% the original position, that you can change that and bend it a little bit and make it look larger so that you'll cut more. Well, we're pediatric dentists. We don't do icky stuff. But, you know, they always think, oh, you know, you guys are going to do something bad. So it never went too far. But what we found with that is secondary caries were basically same diagnosis as primary caries. We could see them the same as primary caries. And we validated all those. So by this time we had a heck of a lot of happy kids that were in our studies because they're getting $25 a pop for these teeth they're sending back to us. So everybody's happy. So we finish it, and what were our big concerns? Well, number one, the head was kind of big, very cumbersome on little kids. Teenagers, great. Little kids, a little tougher. Next, the cost. The biggest one was cost. So we went to, by the secondary caries one, we went to a newer unit, which went from, you know, $85,000 down to $15,000. You guys going to go buy one for every op for $15,000? I mean, it's unpractical, totally impractical. So, you know, by now, obviously, it would be much lower and it'd be effective, but nobody wanted to progress with it because insurance wouldn't pay for it. And, I mean, you got to get paid for what you do, especially if you're paying $15,000 for a piece of equipment. So what happened at the end of our trial? This is a paper that was published in the Journal of Dentistry, and this is 2006, guys, and we were just finishing up our stuff that we did before we started doing restorative and tracking it with QLF. And I'm not going to talk about that because we're just doing diagnostic stuff today. And this is the standard of care still. After almost 20 years of work, but at least 10, we're at the same place we started. We're using explorers and mirrors. We're still doing it today. And so things kind of died down in the world of diagnostics. Well, again, like I said, I'd met Carrie earlier, and now I've met more people, Jessica here. So I got the information on BlueCheck, which was not called, they didn't have a name for it when it was first introduced to me. And it was designed for early caries detection. Again, can diagnose at 50 microns. The deeper the lesion gets, the bluer it gets. And more intense the color is. But what made it critical for me to be talking to you today here, it didn't have FDA approval until just recently, and now it's marketed actually within the United States. So this is kind of a primo time to talk about it because it just started getting sold several months ago in the United States. It's been in Australia for many years. So this is through Incisive Technology out of Melbourne, and the whole idea, like I told you, is you put this stuff on and it goes into deminned enamel. And if you came from the University of Iowa, which there's only one, or University of Texas, San Antonio, there's 3 more, us in research, we don't talk deminn as a casual thing. We always talk it as pore volume, because as it demins, you get greater pore volume, really. And that's the whole idea of deminn, and you want to catch it before the pores get so big they break away and cause cavitation, right? So what this does is it takes the blue dye, which is attached to the protein, hemoglobin, and it goes within these systems, okay, where there's deminn or pore volume. So it's specifically designed molecule consisting of the protein, like I said, hemoglobin, and it selectively binds to these sites of deminn. Well, actually, it's the pores, right? So as demineralization occurs, the subsurface porosity develops. You know that, right? Pores. And it creates increase of hydroxy apatite crystal. You don't have that heavy layer that is at the surface layer of enamel as it demins. So you can target this dye, and it carries, as I said, the protein is hemoglobin that carries with a cross-linker a dye. And the dye is covalently linked, I told you, to hemoglobin. And that's what makes it visual because of the dye, the blue color. So, the first thing I do whenever I'm talking about it, I talked with the company and said, what's the publications? And by that time, I'd already done a lit review. And there were pretty significant publications, not a lot, but significant enough. I thought it gave me a good feel for what's going on. So this is a trial published in Caries Research. Caries Research, pretty powerful journal, very difficult to publish in, highly reviewed. 60 extracted teeth, 30 had orthodontic brackets bonded to the facial surface, and the other 30 was just normal, right? So half of them were challenged with artificial caries solution, half from each of those 2 groups, for 7 days and the other half for 14 days. QLF, now remember, that's been validated by us before, confirmed deminn, so we know that's accurate. So then they applied the BlueCheck and evaluated for blue stain and wanted to know, well, what's the depth and does color respond to depth? And that was a real problem with QLF for a while, but I think we managed that relatively well. We had some bioengineering people that worked with us on the true fluorescence, but that's a day of the past. So what the actual confirmation on that is QLF confirmed demineralization on all 60 specimens, right? They all were exposed. Didn't matter if it had a bracket or not a bracket. If it was exposed, which it was, to deminn, it deminned. All of the deminned specimen showed blue dye penetration. Internal controls. Some of it, the tooth was varnished out, okay? And so the varnished out tooth was the control, natural enamel that never got exposed to the deminn solution. And so they all showed no dye penetration. So, hello, Don't have to be a rocket scientist to figure that out, you know. And so it had a sensitivity of 1.0, specificity of 1.0. Come on, guys. You don't get better than that. I mean, it's accurate. If it's D-min, it's accurate. It's really D-min. So, I mean, I'm going to go through the application so you kind of understand it better, but I wanted to show you the research first, in case you have to run out and get a drink or something. But I think the thing that I wanted to make sure I did, and I hope I made this clear at the start, the whole idea when this was being developed was to diagnose early, not to do restorative. It was to follow the lesion. So, with our QLF, we could follow the lesion, sometimes at remin, you could see it, and you could follow D-min. The same thing's true with this BlueCheck. When you put it on porous enamel, D-min enamel, it will turn blue. And it will be a lighter blue if it's reminning. And so you can take a picture all along the way and have it in your data bank, and you know exactly where you're at. So I like that. So this is the next publication I think is pretty critical. Detection of artificial caries-like lesions with the blue hydroxyapatite binding porosity probe. Again, it's the same thing, this is BlueCheck. So they did artificial caries-like lesions, and they created them with lactic acid gel for 6, 12, 24, 72, and 168 hours, okay? They put on the BlueCheck for 2 minutes, rinse with water, and then they evaluated the color changes with spectrophotometrically, and this is a standard. If you're not particular with the ABS color spectrum, it's just the natural color spectrum, but if you're kind of jogging your mind for where do I see this all the time, it's on all the bleaching studies you read. That when they're trying to tell you how much whiteness, originally they used the Vita shade, took a picture next to the Vita shade, but everybody eventually, they moved to the LAB because there's no bias in it, because you're still kind of interpreting stuff when you use an artificial system. So this is just a standard verified technique for color change. And so then they were characterized with quantitative light induced fluorescence, and they used Vickers microhardness and transverse microradiography. All standard things you would think they would use. So what do they see? Well, the untreated controls, no color. I mean, heck, they were varnished out, right? All lesions stained blue, becoming significantly darker, meaning the L, for lightness, that's what the L is, increased. And overall, the color difference changed, increased significantly according to the depth. Doesn't that mean? So they were all significant, but at different levels according to different depths. So what do you do? Kind of simple. I hate to wasting your time here, but you paint it on. Hello. Rinse with a little bit of water. I would recommend taking images, but you don't have to unless, obviously you're going to do it if it's blue, but if it's not, you don't have to. And that way you have a baseline. And then you brush the kids' teeth or have them brush their own teeth, and just normal toothpaste takes it right back off. So real simple. And that takes me back when I'm talking to people, and they say, oh, I remember those dyes that did that. I said, me too. Remember the one through Ivoclar that turned everything red? And if it was really deep, it was really dark red. Hell, you couldn't get rid of that unless you cut it off, Remember on Denton? It was, and so this doesn't do that. So you paint it on the kids' teeth. Have them take a sipper of water and rinse. Take your picture, and then they just brush with normal toothpaste, and that's it. I mean, it's pretty simple, guys. So, the sensitivity with occlusal caries at 50 microns deep. Again, you can see, you really can't see that well. I know you as pediatric dentists, you see it. You can see that opaqueness right there. But I'm telling you, a parent cannot see that. If you're sitting there with a mirror and you show the parent, even if you have a camera system, I'm telling you, they don't see that well. But you stick a dye on there, oh, they can see it. They can see it crystal clear. take a picture in case your insurance company goes through these spastic reviews that they do now and then, and you got proof. And this is what it looks like under polarized light microscopy. And sometimes I take it for granted everybody understands this stuff because I've worked with it so much, but no, this is blue enamel, and this is a fissure on the occlusal part, So they can measure at 50 microns, but I think this slide says 1,000 words. So it shows the depth of the etch over here, and then the time that it was in solution, and they're consistent on the more it's there, the bluer it gets. So it's pretty clear. And so if you really are following these with pictures, you can tell from visit to visit if it's getting lighter or darker or staying the same. And I would hope, if it's not carious or if it's improving, you treat accordingly. If it stays the same, you might want to put a sealant on it or something like that. But the whole idea is you see stuff early. Obviously you take the blue off before you put your sealant on or whatever. But you can really intercept early, and I think that's healthy. So I put this slide in. This is from Insights for Technology. They were very kind to provide this. Sorry. As you know, to get FDA clearance, and I don't know if all of you know that, but you have to show biocompatibility. I mean, it's mandatory by the FDA. So you have to show it's biocompatible. It is. They've done studies for both toxicity and biocompatibility, as must be done. Under the worst case scenarios, it's, number one, it's safe. Number two, you can remove it, which is a big thing. You get a dye on there and you can't get it back off, well, you might get some unhappy parents, So anyway, and they have enhanced safety through sources that they use from cattle, like red blood cells for the hema. We're talking about the hemoglobin base. That is the linker, the protein that carries the blue dye, right? Additional chemical treatment in the preparation of BlueCheck that can be expected to further increase the safety of margins. So, to simplify it, because we don't have much time, it's safe. CDT code. Well, it's going to go in for submission. I think it's going to be reviewed. Marge, is Jim Nickman here? Anybody here on the ADA code team? Do you know when the code's going to be reviewed?
Well, we submitted last year, and the ADA actually advised us to use D0600.
E0600. But so hopefully when that's submitted, it'll gain a CD code. Because you got to get there to be able to ever charge, right? And that's the bottom line. One day you hopefully will charge, but I think up until that time, it might be a benefit to you because you can see how early stuff is occurring. So in summary, BlueCheck is pretty new. Well, for here in the United States, it's new. Australia's been around a while. It has FDA approval. It functions, I think I made that clear, by directly exposed to mineral crystals that have been demineralized, right? The pores and things like that. Sensitivity up to 50 microns. It's the only thing I have seen since QLF that's that accurate. Works on both smooth surfaces and occlusal surfaces. You paint on, rinse with water, and remove it with toothpaste. You can use peroxide, but toothpaste is simple, right? And I'll tell you what I like. When parents tell me their 3-year-old brush is great, they're really good. I can see my dental assistant's eyes just start rolling because they know that is the one and only time I'm getting out the red dye, the disclosure solution. And they hate it when I do that because the kid always sneezes, then we all polka dotted the rest of the day, But the thing is, people think their kids brush their teeth well. And so I think, number one, it can show anything to a parent that's there, and it shows you too, but you might already know it. But the parent, I can guarantee you, doesn't know it. and it comes off simple, which keeps you happy and probably the parent happy. Clinical verification, come on, specificity of 1.0, sensitivity 1.0. I mean, heck, that speaks for itself right there. And of course it has FDA and clearance, and it became available just recently in the United States. So what's all this mean to you guys at the dentist? What's the bottom line? Well, one, you can see it earlier, right? So why do you care if you see it earlier? You can intervene earlier. And I've been to so many, and I know you have too, risk assessment panels, and listen to them. And we know when strep counts are higher, over 10 to the 6th, the kids at higher risk. If they didn't live in a fluoridated community, they're at higher risk. And everything else, you go through all the gambit, but none of them are perfect predictors. What is the only predictor we have that we know a kid is at high caries risk? The presence of caries or previous caries. I mean, you see a blue spot, you know this kid's at high risk because they got caries. That doesn't mean you got to start cutting. That means you can intervene appropriately according to how deep it is. And so that's what I like about stuff like this. And that was a whole part of my goal my whole career, and I kind of didn't get there. But anyway, so by being able to do that, not only can you moderate lesions over time, but I truly believe it is completely related to risk assessment. You see early caries, you know that kid's risk. And so you're going to bring them at 1 year, you're going to bring them at 6 months, you're going to bring them at 3 months. And I think a lot of it comes down to what you see in the mouth. And it's easier if you can show the parent, because parents never see caries that well unless it's some gaping hole, right? So I think we have to get reliability and cost effectiveness associated with this too. So this is the way I interpret it for you as a practicing dentist. You have the opportunity to come in early, educate the parent. Most of these kids are too young to be educated, but once they're at the teenage years, and they're at that age where they can go out and buy, in Texas, the Big Gulp. 64 ounces of pure sugar in an acid base. Oh man, and they can suck on that baby all day long. And they're getting D-min off and on, as you know. And so you need something that's reliable, accurate, and can track stuff. Because as you know, caries is an ongoing process. D-min, remin, D-min, remin, because your saliva is super saturated with calcium phosphate. And so it's always remin, D-minning. And you're trying to override the remin session over the D-min session, basically. And so sometimes if you see early caries, it's just as simple as telling the kid, use a fluoride rinse. That's it. So I want to thank you guys for your time, because I know this is the last one of the day. I want to thank Jessica, who's the Senior Vice President of Clinical and Scientific Affairs for Incisive Technologies. I want to thank Dr. Jonathan Magnum. He's over San Francisco way, and he put some of these slides together that helped me also. And Rachel's back there in the back. You can wave to everybody. And you can find her at booth 1003, as well as Jessica. And I really encourage you to just go visit them, because I don't have enough time to say a whole lot. But they can get into it very thoroughly. But hopefully I said enough that you grasp basically what it's all about. So you can run for your cocktail, and I'll be around here for a while to answer questions. But thanks for your patience. I can't believe all you guys are here. Thanks. Okay. Questions? Yeah.
Just for the application, do you need the tooth to be free of like saliva or plaque or anything?
No, well, it got to be plaque free. Kind of like when you're doing fluoride varnish, it doesn't have to be perfectly dry, so you got to get the plaque off.
After polish?
Yeah, then paint it on.
Do you paint it on with like a proxy brush, or it just doesn't work?
Yeah, it was just basically, you could do that. Basically, this was just a fluoride varnish brush.
Oh, fluoride varnish brush.
Yeah, but you could use any of them. Yeah. Okay.
We have some how-to videos on our website and our YouTube page too that have a full how-to. So you just want to have the bio.
Bye, Jed. So And they have at their booth some nice videos and stuff, but you also can find it online if you want, if you're busy. Any other questions? Yeah, Eric?
That occlusal you showed on that premolar, that stain, does
Right.
it come out pretty good with just a regular brush?
Yep.
Or is it just, I mean, it looks like it's kind of, like not like a silver diamond kind of thing.
No.
You get that. It's going to come right off.
I'm glad you brought that up, because I don't know about where you guys live, but down in South Texas where we were, all of a sudden the pediatricians were having their nurses paint on SDF. I'm like, with no informed consent, and you know that doesn't come out. And if there's even slight DMIN, their teeth are black. And who do you think they come to? After they go to the pediatrician, the nurse puts it on and the tooth turns black. You think they go back to them? Oh no, they come right to you. What happened? And that's not fixable. So no, it's not like that at all. You can brush it off.
You brush it off, throw a seam and all that.
Yeah.
If you do nothing, just with saliva, it'll come off in a few hours.
Okay.
Yeah. I think another question was, can you put a seal on after it? Yeah. You can still etch it. Yeah.
Can you see it in proximal lesions?
Excuse me?
For proximal lesions?
Yeah, can you use it for that?
Yeah.
Yeah, it'll show up proximally. You don't see it quite as well, but it kind of shows you on the video and stuff like that. And smooth, because it's smooth surface, right? So, you know, you don't see it quite as well, but yeah, you can see it.
Yeah, so sometimes like directly in the contact it's limited, but you know, just look kind of at the
Yeah.
line angle. If you're seeing a lesion there, you can
Okay. You had a question?
I must have come after this part of the presentation, but how long after it's painted does the stain actually appear?
Within 2 minutes. And then, but it's pretty blue, so you have them rinse gently, and then that washes the excess away, and that's when you can see the blue.
And it can stay over time?
Well, until you haven't brushed it. Well, or if you don't have them brushed it, it'll still come off in a few hours just from natural saliva.
Okay.
Yeah. Okay. Yes.
Do you know what percentage roughly of posterior teeth clinically test positive for BlueCheck?
What percentage? What?
Of like posterior teeth test positive for BlueCheck. So if you were to have like 10 patients in your office, you use them on every patient, how many of those teeth would actually turn out to be discoverable, whereas previously they would be still if they
Well, if it has any DMIN, it's going to show up.
do you know what percentage of the population? Has
Well, I guess I would just come back to what's the prevalence of caries. That's what it all comes back to. And in the United States, by the time a kid turns 13, 90% have had caries. So you figure that out, yeah. And if it becomes a lesion, it's going to show up. But that's going to come back to what we always are doing: try to get kids in. You know, get them to see a dentist, for God's sakes, and that's half the battle. And if you can see stuff early and convince a parent that you got some problems here, I think that's going to help solve your problem. Okay. We good? Oh, God, yeah. I'm sorry. What you got?
No, in the process of doing your trials, did you have any vegetarian or vegan families ask you more questions or refuse this? I'm just thinking of my granola patient population.
Well,
Because we all have
you
them.
know, I'm from Texas. We're kind of big meat people. We didn't even ask them if they were vegetarian because we just assumed they're munching on a cow. But no, I don't know. I really don't. Everybody good?
Is that part of the consent process?
I mean, yeah, I guess it is getting more popular, but no, we've never asked it, so sorry. All right. Everybody have a good evening, and I guess we have a half day tomorrow on Sunday, so cool. All right.
Going to stop by Iowa?
Oh, absolutely.
We'll see